Okay, let me go ahead and introduce Michael Stroup. He's a professor of neurotology and neurophysiology in München, right? Interested in diagnosis of vestibular and ocular disorders. He has authored 447 publications. Wow. So it certainly is a phenomenal honor that we hear words of wisdom from Professor Stroup. So, Michael, take it away.
Ladies and gentlemen, colleagues, first of all, I would like to thank you for your kind invitation. It's been a great pleasure, privilege, and honor. I'm going to give you an update on the diagnosis and current treatment of peripheral vestibular disorders. First, I'd like to begin with my conflicts of interests. I'm chief editor of the Journal of Neurology and Frontiers of Neurotology. As you see, I have received speakers honoraria from various companies, so I think I'm quite well balanced. The same is true for my activities as a consultant. In this context, I have to explicitly mention that I'm the inventor and distributor of the M classes, so little devices to examine patients with nystagmus. And my youngest daughter, Amelie Christine, she programmed the Positional Vertigo App. I'll talk about that in a few moments. Finally, I have to mention that I'm first author of a 400 pages book, which will come out in October this year, Springer Nature, Vertigo and Dizziness, Common Complaints, with about 200 videos, very clinically oriented. Today's topic, peripheral vestibular disorders. Before we go into the specific disorders, I'd like to show you this slide, which is very important for the understanding of the pathophysiology, as well as the signs and symptoms of our patients. There are patients who have, as the leading symptom, postural imbalance and dizziness, instability of gait, movement-induced oscillopsia, typically getting worse in darkness and on uneven ground. And these are the key features of bilateral vestibulopathy. On the other hand, there are patients with a peripheral vestibular disorder with a leading symptom of acute onset of most often severe spinning vertigo, spontaneous oscillopsia, and a tendency to fall in a certain direction. This is the leading symptom of an acute vestibular syndrome, namely, if it's peripheral, acute unilateral vestibulopathy. And thirdly, and these are the most frequent presentations, patients can have an inadequate paroxysmal excitation or rarely inhibition of the peripheral vestibular system. Examples are Bppv, vestibular paroxysmia, and also Meniere's disease. But in most of these patients, it's an excitation and not an inhibition. What are the specific underlying diseases? Actually, there are 6 frequent peripheral vestibular disorders, and we are going to focus on the most frequent ones. First, Bppv. Second, Meniere's disease. Thirdly, acute unilateral vestibulopathy, which you can still call vestibular neuritis. Then we have superior canal dehiscence syndrome, or syndromes of the third mobile window, a term which I definitely prefer. Then we have vestibular paroxysmia with recurrent short attacks of vertigo, and finally bilateral vestibulopathy. Here, the underlying etiology remains often unclear. However, we have done a recent study showing that many of these patients do have certain mutations. What is the relative frequency of these peripheral vestibular disorders? Here you see data from our dizziness center in Munich on almost 40,000 patients. Bppv is number 2. And the second most frequent peripheral vestibular disorder is Meniere's disease, acute unilateral vestibulopathy, bilateral vestibulopathy, vestibular paroxysmia, and syndromes of the third mobile window, namely superior canal dehiscence syndrome. What will help you very much in your clinical practice is the almost complete international classification of vestibular disorders. Over the last 13 years, we have published 16 papers in the committee, and we have now classified or reclassified most vestibular disorders. Recently, acute unilateral vestibulopathy and vascular vertigo, as well as superior semicircular canal dehiscence. And fortunately, you can download all of these papers from the website of the Journal Vestibular Research for free. Print them out, and you're really up to date in terms of the current diagnostic criteria for your clinical practice, but also for clinical trials. So I'm going to present you the most frequent ones, and most of them will be introduced by a short video quiz. Listen to the patient, please, and try to make the diagnosis.
You've come to us because of dizziness. When did this all start?
2.5 days ago.
Was this vertigo, or was it a staggering dizziness or unsteadiness when walking?
Vertigo and unsteadiness when walking.
Is it still continuing?
Yes.
Did you have other symptoms apart from vertigo?
Nausea and vomiting.
In addition to the vertigo, did you experience any loss of hearing, pressure in your ears, or tinnitus?
No.
When you felt dizzy, did you experience any facial numbness, paralysis, loss of coordination?
No.
Loss of sensation in your arm and legs?
No.
Apart from feeling dizzy, did you have a headache or sensitivity to light or noise?
Headache.
When did the headache appear?
After about a day.
Thank you very much.
So what is the correct diagnosis? Well, what will help you definitely is the clinical examination. Patient is looking straight ahead. You put on Michael's glasses, and then you can see a nystagmus with a horizontal torsional component beating to the right, which was suppressed by the patient. So this is a typical feature. And if the patient looks into the direction of the fast phase, the intensity of the nystagmus increases. And important to note, if the patient looks into the opposite direction, there should be no change of direction. That means no gaze-evoked nystagmus. Then you will look whether the patient has a skew deviation, which is not the case. And finally, you will do the head impulse test to look for a peripheral vestibular deficit. And when the head is turned to the left, you can see a refixation saccade. So the diagnosis is acute left unilateral vestibulopathy. And the diagnosis primarily is based on the patient history and the bedside examination. Here, another patient. You see a very tiny nystagmus to the left. And if you put on Michael's glasses, you see the intensity increases. And in addition, what the patient should show is a pathological head impulse test. Ideally, this is performed by a video head impulse test. So horizontal torsional spontaneous nystagmus, fast phase towards the more active labyrinth, easy to remember, partially or completely suppressed by visual fixation, pathological head impulse test, no central signs or symptoms, namely no prominent skew deviation and no gaze-evoked nystagmus in the opposite direction of the spontaneous nystagmus. And this paper here just came out. We published that a month ago. And these are the diagnostic criteria for acute unilateral vestibulopathy. And I will go through some of the specific aspects and also on the differentiation between an acute central and an acute peripheral vestibular syndrome. So sustained spinning or non-spinning vertigo, duration at least 24 hours, spontaneous peripheral vestibular spontaneous nystagmus, unambiguous evidence of reduced VOR function. That means a definitely pathological head impulse test. If unclear, you need a video head impulse test and or the calorics. No evidence for central neurological or acute audiological symptoms. No acute central neurological signs. In terms of oculomotor, no pronounced skew deviation or no gaze-evoked nystagmus. When it comes to visual fixation suppression of the nystagmus, there's one important thing which you have to know. Also, more than 50% of patients with an acute central vestibular syndrome and nystagmus can reduce or suppress this central nystagmus. It depends on the structures which are impaired. Secondly, vestibular skew deviation you also find in patients with a stroke. And you find it in patients with an acute unilateral vestibulopathy. In contrast to what is commonly believed, patients with an acute unilateral vestibulopathy can also have a skew deviation. However, it's below 3 degrees. For your clinical practice, if you can see a clear skew deviation in an acute vestibular syndrome, it will be most likely central. But only 30% of patients with an acute central vestibular syndrome do have a skew deviation. If you see a very tiny skew deviation, this is most likely peripheral, but it can also be central. So be careful when you look for skew deviation. And the same is true when you look for a gaze-evoked nystagmus, the so-called Bruns nystagmus, in the opposite direction of the spontaneous nystagmus. Here again, only 30% of patients with an acute central vestibular syndrome have a Bruns nystagmus. However, none of the patients with acute unilateral vestibulopathy should have a gaze-evoked nystagmus. If you see a clear gaze-evoked nystagmus, it is most likely central. Now we move over to the etiology of acute unilateral vestibulopathy. Many years ago, we have performed a lot of molecular biology studies and detected, for instance, in 60% of human vestibular ganglia, which we got from forensic medicine, HSV1 DNA. We also found in 70% the latency-associated transcript. More recently, and we have the DNA for more than 6,000 patients with vertigo and dizziness now, we have performed several genome-wide association studies. And when it comes to vestibular neuritis, we found single nucleotide variants in the host factor for HSV1 replication. And this strongly supports that the replication of HSV1 is relevant in acute unilateral vestibulopathy. And in another paper, we demonstrate an association of the high-risk allele for herpes labialis severity and vestibular neuritis. So a lot of strong arguments that it caused by the reactivation of a latent herpes simplex virus 1 inflammation. What about treatment? Well, we have 3 or 4 therapeutic principles. First, as we demonstrated in a paper in the New England Journal of Medicine, if you give the patient methylprednisolone, we normally start with 100 milligram for 3 days, then 80 milligram for 3 days, and so on, you improve the recovery of peripheral vestibular function. The second aspect, of course, is a treatment of the symptoms, and our favorite is dimenhydrinate, an H1 antagonist. Why this is so special, I'll tell you in a few moments. Then there are a lot of drugs which potentially improve central vestibular compensation. I'm going to show you some animal studies. And we have clear evidence for the efficacy of vestibular exercises to improve central vestibular compensation. So basically a 4-week treatment with steroids, tapering the dosage, a 4-week treatment with vestibular exercises 3 times per day, 15 minutes. And about the other aspects, we are going to talk in a few moments. Now, let's talk about symptomatic treatment of acute vertigo. Here you see a long list of potentially active molecules, dimenhydrinate, ondansetron, benzodiazepine, and so on. Our favorite by far is dimenhydrinate because it specifically is an antagonist of the histamine 1 receptor. If it does not work, you can give the patient ondansetron, very popular in chemotherapy, about 4 milligram, 3 times per day. Number 3 are benzodiazepines. I do not give any drugs as a neurologist which interact with the dopamine receptor because they can lead to Parkinsonian syndrome. Namely, as we know, patients often take it much longer than normally prescribed. Another candidate which may have a double effect, reduction of symptom and improvement of central compensation of beta-histine. As we demonstrated in this worldwide survey, it's by far the most frequently used drug. However, the problem, as you will see later also for Meniere's disease, is the dosage, namely due to its pharmacokinetics. So we have established an animal model with a chemical labyrinthectomy, and this allows us to evaluate the potential effects of any drug on central compensation. So the animal is evaluated on a behavioral level, but we also do a micro FDG PET to localize the site of action. Here, one of the experiments, we gave beta-histine, IV or via an osmotic pump, different dosages, and with and without siligeline, an inhibitor of monoamine oxidase B. I'll come to that later. So there's clear evidence that beta-histine as an H1 agonist and H3 antagonist improves central compensation, which you here see in a dosage of 10 milligram per kilogram body weight. And here, these columns over a period of 30 days clearly show a reduction of postural asymmetry. This effect is dose-dependent. The higher the dosage, the higher the efficacy. But it also depends on the way how it is applied, because with an osmotic pump, you see the highest clinical effects. And therefore, at least from animal studies, we would recommend beta-histine. We also observed a benefit when we looked at the gait of the animals and measures the spontaneously chosen gait velocity. On the left side, a control. On the right side, an animal treated with beta-histine. You see the animal is much more agile. If you quantify that, you see here on day 7 that the spontaneously chosen velocity of the treated animal is 5 times higher than the animal which is not treated. So there's a clear benefit. Finally, we were also able to localize the site of action, and this explains the double effect. What you see here are the results of a micro FDG PET, which is very challenging in a small rat brain. Here, day 1, the yellow spot indicates an increased metabolic activity on the lesion site. This explains the symptomatic effect. It reduces vestibular tone imbalance. During day 3, 15, and 30, we have evidence for acceleration and improvement of central compensation by activation of cerebella, but also of spinal structures. So animal studies show a clear benefit. And this study here, published in 2019 from a Chinese group, shows clearly the relevance of the histamine 1 receptor in central vestibular compensation, because it's much more impressed after a unilateral vestibular lesion on the affected site. And on the other hand, if you block the H1 receptor, you delay and decrease central compensation. So clear evidence, histamine 1 receptor is very important for central compensation. The problem, as you will see with beta-histine, is the plasma concentration. So to summarize, treatment of acute unilateral vestibulopathy, vestibular neuritis, steroids for 4 weeks, tapering the dosage, and we have also increasing cumulative evidence from meta-analysis showing an improvement of vestibular function due to the reduction of the swelling of the nerve. Antiviral drugs, as we showed in this study in the New England Journal of Medicine, had no effect. I think they just come too late. Treatment of symptoms, diamine hydronate, 50 to 100 milligram, not longer than 3 days. Beta-histine, theoretically active, and improvement of central compensation by vestibular exercises. So this is the current status on how to treat vestibular neuritis. Now listen to two elderly ladies with a typical atypical patient history and try to make the diagnosis.
Dr. Mittens, why do you come to our hospital, please?
I have a sort of dizziness and imbalance.
For how many days or weeks?
3 or 4 weeks.
Did you have that before?
I had that months ago and even years ago.
Do you also have spinning vertigo now?
No spinning.
Do you have positional vertigo?
No.
Thank you very much.
So the lady on the right would tell you a similar story. So typical atypical patient history. What would you diagnose? Well, actually, both ladies had Bppv of the posterior canal on the right side. And many patients, namely elderly patients, just complain of postural dizziness and imbalance. And therefore, the take-home message from my side is do the diagnostic positioning maneuvers in every dizzy patient, independent of the patient history. In 2016, we published this paper, and this turned out to be extremely helpful, this biophysical model of Bppv. What you can see immediately is if you turn the labyrinth by 90 degrees, the crystals do not move 90 degrees, but only 70 degrees. As I saw that, I immediately got the idea that we can modify the diagnostic and therapeutic maneuvers for Bppv, and this turned out to be very helpful. Let's begin with the diagnostic Sumo plus maneuver. The clue is that you overextend the patient's head by at least 60 degrees below Earth horizontal. What is happening during these extra 60 degrees? Well, as you saw on the model, the crystals move on another 60 degrees into the direction they should move. This will increase the sensitivity of the diagnostic maneuvers. And theoretically, it should also increase the efficacy of the therapeutic maneuver, which is now called Sumo plus maneuver, because if you extend the body by another 60 degrees below Earth horizontal, the crystals move beyond the vertex of the canal, and then it should be more likely that they move into the direction they should move. And this is something which we simulated, and the simulation were done by the Bandaris from India. You see here the Sumo plus maneuver for the right posterior canal. On the right side, you see how the crystals are moving. You see they move very slowly, and you should keep that position for the therapy 60 seconds. And then the patient is moved by 240 degrees into the opposite direction, with the head always turned toward the 45 degrees. And you see here what the crystals are doing. They moved beyond the vertex of the canal, and then they end up in the common cruise and finally land in the utricle. So that was the theory. And based on the theory, we performed a multinational randomized single-blinded prospective trial. Was very simple. The primary endpoint was how many days did it take until the patient cannot induce an attack of vertigo. 200 patients included. Finally, 194 were analyzed. And in the Sumo group, it took 3.6 days. In the Sumo plus group, only 1.8 days until patient recovered. The same we did more recently with the Apley maneuver in comparison to the Sumo plus maneuver. Was an identical study design, and here you see the result. For the Apley maneuver, it takes about 3.3, and for the Sumo plus only 1.9 days. So the Sumo plus maneuver is superior to the Apley maneuver. One thing which will make your life easier, namely the life of your patients, is the Positional Vertigo App, which was actually programmed by my youngest daughter, Amelie Christine, at the age of 17. And the English version, you can hear the voice of Michael Halmagi, who gives precise instructions to the patients on how to precisely perform the Sumo and the Sumo plus maneuver. One thing which we always have to keep in mind is that the angle is correct. This is true for the Apley maneuver, and this is also true for the Sumo maneuver, because if the canal is not parallel to the gravitational vector, the crystals will not move. They're either attached or gravitational forces are too low to move the crystals. And therefore, the orientation, if you do the Sumo and the Sumo plus maneuver, of the head should be always 45 degrees, turned towards the healthy side, so that the canal is parallel to the gravitational vector. And one thing which turned out to be very helpful is virtual checking whether patients perform the maneuvers, the self-maneuvers, correctly. You see here, the couple here on the left side is very much engaged, but the maneuvers were not successful. So remote management, virtual checking is very important. And here you see a patient performing the Sumo plus maneuver for the right posterior canal in a very precise way, and she recovered after 1 day. So conclusions: the Sumo and the Apley maneuver versus the Sumo plus trials. The Sumo plus maneuver is superior to both. It confirms the prediction of the biophysical model. Keep the angle of the head always 45 degrees. And for your clinical practice, switch from the Apley to the Sumo plus maneuver from now on. Now have a look at this patient. Recurrent episode of spinning vertigo. What do you diagnose? It's a horizontal linear nystagmus beating geotropically. Now the right ear is down. Can have a very high intensity. It normally lasts 30 seconds. And now have a look what is going to happen if the head is turned from the right to the left. And again, you see a horizontal linear nystagmus with a lower intensity. So the diagnosis is horizontal canal Bppv. The mechanism is canalolithiasis, and the affected side was the right side, the side with the higher intensity. If you examine patients for horizontal canal Bppv, please elevate the head by 25 degrees to bring the horizontal canal in a vertical position parallel to the Frankfurt line. And here you see another patient, right ear down, left ear down. It's a linear horizontal geotropically beating nystagmus. And the affected side is the side with the higher intensity because it's due to the asymmetry of the vestibular ocular reflex. In the horizontal canal, a pedal movement leads to an excitation which is stronger than inhibition. What is the treatment? Well, we have a lot of treatment maneuvers. And in 2020, we published this review summarizing all the maneuvers. And even more important, we did also a simulation for the 6 recommended treatment maneuvers for horizontal canal Bppv. This paper was published in 2021. And it turned out that the modified roll maneuver is evidently the most efficient one. Why do we call it modified? Because in contrast to what is normally recommended, the patient has first to turn the patient toward the affected side, the side with the higher intensity of the nystagmus, because then you reach all the crystals during the subsequent roll maneuvers towards the healthy, non-affected side. And this can be done several times. So really you remove the crystals from the horizontal canal, and this should be followed by a rest resting 12 hours on the non-affected side. I call it roll and rest. And cupulolithiasis is basically the mirror image of canalolithiasis. So the nystagmus is beating apogeotropically, and the affected side is the side with the lower intensity, because here the crystals are attached to the cupula. How do we treat? Well, again, a lot of maneuvers have been recommended and published. What we recommend basically on biophysics is to transform a canalo into a cupulolithiasis by head shaking. So the patient should shake the head about 100 times per day, and then you transform cupulolithiasis into canalolithiasis, and subsequently you treat the patient as a canalolithiasis. Clinically, you can discriminate that by the change of direction of the nystagmus. So, summary, horizontal canal Bppv, it's about 5 to 10% of the cases. It's a linear horizontal nystagmus. Geotropically, it's a canalolithiasis. The affected side is the side with a higher intensity, and the treatment of choice is a modified rollover maneuver, first toward the affected side and then towards the non-affected side, and rest on the non-affected side for 12 hours. Cupulolithiasis, it's the mirror image, it's apogeotropically nystagmus. The lower intensity indicates the affected side. These patients, by the way, can have persisting spinning vertigo, because if they move the head up or down, there will be a persistent deflection of the cupula, which is often misdiagnosed as acute unilateral vestibulopathy. Therapy is head shaking and then treatment like canalolithiasis. Okay, now look at this patient here, and you see the nystagmus. What do you diagnose? So it's a downwardly beating nystagmus with a torsional component. What is that? That's a typical feature of anterior canal Bppv, and anterior canal Bppv is, by the way, the mirror image of posterior. So it's not beating vertically upward, but vertically downward with a torsional component. And the torsional component, by the way, depends on the direction of gaze. So the precise diagnosis is made in the supine straight heading position, and you get a predominantly vertically downwardly beating nystagmus lasting less than a minute. And whether the patient has a torsional component depends on the direction of gaze. If the patient looks into the direction of the affected anterior canal, you get a pure vertically downwardly beating nystagmus. In 2009, the Iacovino maneuver was recommended. However, based on several simulations which we have done, it turned out that the original Iacovino maneuver should theoretically not be really effective. We have modified the maneuver and simplified the maneuver, and theoretically it's more effective. The easy thing with anterior canal is you don't need to know the affected side. So the person lies supine, the head overextended, and then simply get up straight. You see here on the right side what the crystals are doing. They just move and end up in the common cruise. And after about 30 to 60 seconds, the patient should bend the head forward. And this maneuver should be repeated 3 times in the morning, 3 times at noon, and 3 times at night. Basically, this is also what we recommend for all other types of Bppv. As you see here, there's a broad spectrum of differential diagnosis. Other peripheral vestibular disorders can cause positional vertigo. You have to identify the affected canal or canals. Syndromes of the third mobile window can also rarely present with positional vertigo. The same is true for vestibular paroxysmia. Then we have central disorders, namely central positional vertigo. Episodic vertigo can also be caused by orthostatic dizziness. And here on the right side, you see conditions which are associated with a higher risk of Bppv, head trauma, long bed rest, reduced physical activity, age. Of course, you see it more frequently after vestibular neuritis. You see it more frequently in patients with Meniere's disease, vestibular migraine, and reduced hearing. For your clinical practice, this again means do the diagnostic maneuvers in every patient with postural imbalance and dizziness, even though they not complain of recurrent attacks of vertigo. And here you see another patient, supine, head overextended. What is the direction of the nystagmus? It's beating towards the nose. And now the same patient, the left ear down. It's again beating toward the nose vertically. And here you see condition number 3, the right ear down. And again, it's beating vertically downwardly. So if you see a nystagmus in different positions with the same direction, this is central positional nystagmus, because the key feature of peripheral positional nystagmus is that it corresponds to a canal. And this here is central positional nystagmus. This is an otolithic problem, ortholithic disinhibition, depending on the head position, but not depending on the orientation of the canal relative to gravity. So most often it's beating vertically downward. Secondly, as we showed in this review here, it's most often associated with other central cerebellar oculomotor disorders like saccadic smooth pursuit or a downbeat nystagmus, of course, or a gaze-evoked nystagmus. And finally, if you do the therapeutic maneuvers, patients do not consistently respond to the therapeutic maneuvers. Treatment of choice, by the way, for central positional nystagmus is 4-aminopyridine. So, resume for your clinical practice: posterior canal, Sumo plus; horizontal canal, modified roll and rest; anterior canal, modified Jacobino maneuver; and central positional nystagmus. Carefully examine the patient and you will discriminate both. Finally, for Bppv, some caveats. Nowadays, on the one hand, it's overlooked. On the other hand, it's too frequently diagnosed. So a patient comes to you and says, my doctor told me I have Bppv. I question the diagnosis and ask, was it right or left? Or this, he could not tell me. So question the diagnosis, convince yourself, identify the affected site, canal, and mechanism, and do the diagnostic maneuver in every patient with dizziness, even if it comes for the 10th time. You will be amazed to see how many patients end up having Bppv or vertigo squared. That means Meniere's disease, for instance, and Bppv. And finally, if you do the therapeutic maneuvers, and patients should do them at home as self-maneuvers, instruct them precisely how to do it, check whether they do that correctly or not, and the patient should come back according to after 2 to 4 weeks to check whether the maneuvers have been successful or not, and inform the patient that they will have post-repositioning otolith dizziness, which is a good clinical sign. So now we move over to a disease you are all very familiar with. In 2015, we published the current diagnostic criteria, and the most important laboratory examination is an audiogram, at least 30 decibel below 2000 hertz. And what turns out to be very helpful are audio apps, which can be used by the patient before, during, and after an episode. Here on the left side, you see a patient who applied such an audio app, for instance, the MIMI hearing test, for 250, 500, and 1000 hertz, and here from 2 to 4 kilohertz before, during, and after an episode of vertigo. And you can see clearly how there was an impairment of hearing in the low frequency range, which strongly supports the diagnosis because it's required that the hearing is reduced plus minus 24 hours in relation, temporal relation to the episode. Now we come to something which is very difficult. Treatment of Meniere's disease. We performed a worldwide survey on the treatment of peripheral vestibular disorders, including Meniere's disease. We got 234 replies from 188 centers in 47 countries. So I think this was quite representative. Here you see a lot of countries where we got a reply, most often from key opinion leaders. Well, the results were a little bit frustrating because you see here in terms of pharmacotherapy, a lot of drugs are given. So 3 out of 4 doctors give betahistine, which I strongly support, as you will see later. Then herbal medication, diuretics, which are not effective, glucocorticoids, as you will see, which are not effective, diuretics, which are not effective, antibiotics, which are also not effective. And here, an overview of surgical interventions. And you see there's a broad spectrum from endolymphatic sac depuration, neurectomy, labyrinthectomy, intratympanic gentamicin, intratympanic steroids, which are not effective, and other measures which are also not effective. And we have no evidence for the efficacy of the following measures: endolymphatic sac operation, salt, coffee, alcohol-free diet, patients can enjoy their life, diuretics, many antivites, intratympanic dexamethasone, low dosage of betahistine. Gentamicin is effective, but it impairs vestibular and can impair cochlear function and should not be applied in patients with bilateral Meniere's disease. However, keep in mind that after 20 years, 45% of patients with Meniere's disease will develop bilateral Meniere's disease. And here a study from Autonomy, San Diego, which was not published, but presented as a press release, August the 30th, 2017. It was a very well-designed trial. The primary endpoint were days with vertigo. Treatment and observational period were 3 months. Placebo and intratympanic dexamethasone with a perfect pharmacokinetics based on preclinical studies. And what you can see, there's no difference between placebo and intratympanic dexamethasone. But there's a very strong placebo effect of about 60% after 3 months. And of course, there's a trend to the mean in all of these trials. And here's another trial published in the Lancet 2016 from UK. They compared gentamicin with methylprednisolone intratympanically. And you see there's no difference. Baseline, 18 to 24 months. But if you go back to the slide before, there was a 60% placebo effect. And if we extrapolate this placebo effect here to this trial, which was unfortunately not placebo-controlled, you might explain all the effects you see just by a placebo effect. Therefore, every trial in Meniere's disease has to be placebo-controlled unless we have a gold standard, which we do not have yet. So I don't know how this trial could be published in the Lancet. There should have been a placebo group. Then the conclusions might have been completely different. We performed a trial with 221 patients with betahistine, 2 dosages versus placebo. Treatment and observational period were 9 months, and there was no difference between 2 dosages of betahistine, 16 TRD, 48 TRD versus placebo. This is what I expected. What is the problem with betahistine? You will see that in a few moments. It's its pharmacokinetic. And one thing to overcome that is to give a patient very high dosages. Here, 136 patients, and most of these patients here were free of episodes for at least 6 months with a dosage of 96 milligram TID. Some patients need much higher dosages. As I mentioned before, pharmacokinetics of betahistine. Betahistine is metabolized by 99% in the gastrointestinal tract by monoamine oxidase B. And after we realized that, it was very easy to take the next step. We can give a drug which is already approved for Parkinson's disease, which inhibits monoamine oxidase B. And this we did in these patients. We added 5 milligram siligeline, and we could reduce the daily dosage to about 20% with the same clinical efficacy. And the next step was to perform a phase 1 trial in 15 healthy volunteers, and we measured the plasma concentration of beta-histine with and without siligeline. 5 milligram siligeline, and we measured the plasma concentrations for 24, 48, and 96 milligram single dosages of beta-histine. Without siligeline, you can hardly measure anything. With siligeline, you increase the bioavailability by a factor of 100, which is very impressive, and which is the basis, as you will see later, of an upcoming prospective randomized placebo-controlled trial. This work was supported by Cures Within Reach from Chicago. What is the mechanism of beta-histine? Well, beta-histine is an H1 agonist and an H3 antagonist. We demonstrated a vasodilatation in animals, which was mediated by the H3 receptor, which you find here in the subepithelial capillary network. But I think the major mechanism of action is something different. Here you see from this Scandinavian group a very high density of the histamine 1 receptor in the human endolymphatic sac and human endolymphatic membrane. If you activate the H1 receptor, this increases membrane permeability, and thereby it should reduce endolymphatic hydrops. And this also explains why it often takes many weeks to months until we see a real benefit during a treatment with beta-histine. So my recommendation now is the 4 Ds. Correct diagnosis by the diagnostic criteria, drug of choice, beta-histine. I know it's not approved in the US, but hopefully it will be approved. You need either a very high dosage, or you combine it either with 5 milligram siligeline or 1 milligram rasagiline. Both are monoamine oxidase B inhibitors approved for the treatment of Parkinson's disease for decades. Another thing is Meniere's disease is a chronic relapsing disease. This means we need a long-term treatment of at least 12 months, and the aim is similar to epilepsy, free of attacks for at least 6 months, and then you can adjust the dosage. So my clinical approach is 48 milligram 3 times per day plus 5 milligram siligeline. Look at the contraindications. And I already mentioned this clinical trial. First, we will go to the FDA. If the FDA is supporting our trial protocol, we will have a randomized proof of principle phase 2b trial. We compare placebo with beta-histine plus siligeline. And here I think this is very important if you run any clinical trial. You have to have precise diagnostic criteria, which we now published with the Bharani Society. You have to apply a drug, in this upcoming trial, beta-histine plus siligeline. We have to discuss the dosage with the FDA. You have to have a long treatment period of at least 6 months in a chronic relapsing disease. And of course, the trial should be randomized, placebo-controlled, sufficiently powered, multinational, with clinically and meaningful endpoints. Days with vertigo, caloric testing, audiogram, evaluation of tinnitus, and of course, functioning and quality of life. And I would always recommend to go to the FDA before you start a clinical trial. Good. Now we move on with the next entity, and you can listen to this lady.
Ms. Cristero, which symptoms brought you to us?
Vertigo attacks.
How long do they last?
Half a minute to a minute.
Approximately how many attacks have you had in the last 3 months?
About 20, I would say.
20. Do they occur spontaneously, or is there a trigger?
Completely spontaneous.
Spontaneous.
No trigger.
Additional symptoms before, during, or after these attacks?
Circulatory problems, nausea, things like that. And I've had outbreaks of sweating.
Thank you very much. Good.
So what do you think this patient is suffering from? Well, it's probable vestibular paroxysmia. We published in 2016 the Diagnostic Criteria. It's a disease analogous to trigeminal neuralgia, at least 10 attacks of spinning or non-spinning vertigo, short duration, spontaneous occurrence, stereotyped phenomenology, and response to a treatment with a sodium channel blocker. This is very important. One thing is also very important to note. 45% of healthy individuals have a close contact between most often the ICA and the 8th cranial nerve. So MRI is not helpful to make the diagnosis. MRI is only helpful to exclude, for instance, vestibular schwannoma, which can also present with similar short episodes of vertigo. When it comes to treatment, we published this randomized placebo-controlled trial with oxcarbazepine. However, the dropout rate was 60%. And actually, I do not recommend it. My drug and our drug of choice is lacosamide. It's also a sodium channel blocker, dosage 1 to 400 milligram per day. And it's much, much better tolerated than carbamazepine or oxcarbazepine, and therefore it's a drug of choice. Normally, you just need 200 milligram. You can go up to 400 milligram. So keep that in mind as an important differential diagnosis. Recurrent, short episodes of vertigo occurring spontaneously. Consider vestibular paroxysmia, treat the patient. If the patient responds, then the diagnosis is strongly supported. And now we come to another patient, 47-year-old patient who can hear his own eye movements in his left ear. And then we examine the patient with a tuning fork. In this patient, we test the somatosensory system by using our tuning fork. We put it on the sternum. Where do you hear the sound now?
Left ear.
Now we put it on the medial malleolus. Where do you hear the sound?
Left ear.
So this causes an unusual symptom. So you can use your tuning fork to diagnose a syndrome of the third mobile window because of negative bone conduction. And thereby you can also identify the affected site. And here are the diagnostic criteria. So there have to be consistent findings, not to overdiagnose such a syndrome. Bone conduction hyperacusis, sound or pressure-induced vertigo, pulsatile tinnitus is not very specific. Nystagmus induced by changes of pressure or sound in the plane of the affected canal, low-frequency negative bone conduction and enhanced VEMP responses, and a high-resolution temporal bone, slices below 0.6 millimeter. However, take into consideration that about 2% of healthy individuals have a bony defect without being symptomatic. Now we move over to the last entity, bilateral vestibulopathy. Here are the diagnostic criteria: unsteadiness of stance and gait, movement-induced oscillopsia, worsening of symptoms in darkness and on uneven ground. It's the most frequent known cause of postural imbalance in the elderly. To make a precise diagnosis, you need a quantification of the function of the vestibular ocular reflex. Normally you do the V-hit, the gain should be below 0.6 on both sides, and or caloric response, sum of bithermal maximal peak slow phase velocity on each side below 6 degrees per second. Now look at this patient here. He's turning the head slowly to the right and to the left. What do you see? You see saccadic movements. If you examine the patient here, he's turning the head, you see saccadic movements. What do you diagnose? Well, that's not that easy. Normally, if you turn your head to the right and to the left, eye movements are generated by the vestibular ocular reflex. If the vestibular ocular reflex is not working properly, you generate eye movements with smooth pursuit. If smooth pursuit is impaired, as in cerebellar diseases, you will get saccadic smooth pursuit. So this patient has a combination of bilateral vestibulopathy and cerebellar dysfunction. And the diagnosis can be made. This patient has cerebellar ataxia, neuronopathy, and vestibular areflexia. So the head impulse test was pathological on both sides, showing the high-frequency VOR deficit. And in addition, the patient has saccadic smooth pursuit, but you can do one bedside test, then you see both clinical signs. Here you see the saccadic smooth pursuit. So we call that one bedside test, two clinical signs, one vestibular, and the other one is oculomotor. Canvas has become very popular. Two papers came out in 2019 showing this intronic pentamere expansion in the regulatory factor C1 gene. However, as we showed in this paper, only 68% of patients with a phenotype of canvas have the mutation. So it's not sensitive. Secondly, it's not specific, very important to know. For instance, patients with ataxia and chronic cough, they had this mutation in 100%. And also patients who have the clinical feature of multiple system atrophy C, they can also have this mutation. So RFC1 mutations are neither specific nor sensitive for canvas. So it's a complementary test, genetic testing. It's mainly based on a clinical diagnosis. What is the treatment of bilateral vestibulopathy? Well, explanation of the function of the VOR and its deficit. Patient has to know what he or she is suffering from. Then balance training, daily, permanent, and lifelong. Prevention, do not give gentamicin. Treatment of the underlying illness in Meniere's disease, but also in Cogan syndrome. And on the horizon, we have the vestibular implant. Now listen to this last patient.
Mr. Polte, you suffer from gentamicin-induced bilateral vestibulopathy. In November of last year, we recommended balance training, which you have also implemented in an exemplary manner. How long did it take until you noticed a noticeable improvement?
Approximately 6 weeks.
This is very important, and this is something you have to tell your patient. This is very important for compliance, adherence, and persistence. So the expectation of vestibular balance training is there's an improvement after 6, 8, or 12 weeks. This is similar to the prophylactic treatment of Meniere's disease and also of vestibular migraine. Very important for compliance, adherence, and persistence. And the other thing is, if patients stop these measures, they benefit for another 6, 8 weeks, and then they deteriorate. This is something you have to tell your patients also, so that their expectations are in a reasonable range. So we are now approaching the end of the presentation. I think I've given you a quick update on peripheral vestibular disorders. We started with acute unilateral vestibulopathy. We found a gene. Steroids are effective. Vestibular exercises are effective. Beta-histine is at least in animal models effective, but only in a high dosage. For Bppv, posterior canal, substitute the Epley by the Sumo Plus maneuver because it's more effective. For horizontal canal, canalolithiasis, modified roll and rest, cupulolithiasis, head shaking. Meniere's disease, intratympanic dexamethasone is not effective. Beta-histine is effective, but you need a high plasma level, which you can by a high dosage, 96 milligram TID, or by the combination of beta-histine, 48 milligram 3 times per day plus siligeline. Vestibular paroxysmia, recurrent short episodes of vertigo. Treatment of choice, lacosamide, 1 to 400 milligram. Superior canal dehiscence syndrome, consistent findings, very important. And you can also use your tuning fork, treatment of choice if needed, canal plugging. And for bilateral vestibulopathy, I've got you the diagnostic criteria, and on the horizon, we have the vestibular implant. So thank you very much for your attention. And here's the overview of the 6 most frequent peripheral vestibular disorders, including the underlying pathophysiology. Thank you.
Hello, my name is Dr. Kevin Peng, neurotologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.